A little bit of a different topic than I typically present, but I think it's a very important topic given some very recent changes that have happened in the organ transplantation sphere. So let's change that slide. And so by way of objectives today, I want to talk about some of the recent national initiatives that have really been, not just in the last year, but in the last 6 months, that I thought were timely enough that we should really discuss as a division. Talk about the why these are important for the patients in terms of patient access, some of the successes, limitations, and challenges, and then talk about some of the current policy and advocacy efforts that are out there to access for the, in terms of access for the future. So if you can, next slide. So as I mentioned, a lot's happened in the transplant space this year. Next. So breaking news, this is quite the headline. U.S. plans to overhaul the organ transplant system, including breaking up the monopoly power. What is the nonprofit organization that runs it? We'll go into that next. And from there, Congress authorized an overhaul of what they called, quote unquote, the troubled organ transplant system next. And as that happened, there was then a bill, this is July 31st, that came to Biden's desk to help revamp. And then literally just last week, it came to Biden's desk and he signed. I think it's important to know some of these players. All the way to the left with the red tie is our Secretary of Health and Human Services, Javier Becerra, also overseeing all of CMS. And the very tall gentleman next to Biden is Senator Wyden from the fair state of Oregon, who not only is the chair of the Senate Finance Committee, but also was the lead, interestingly, on this bill. Next slide. So let's talk about the why. Many people would talk about, and I'll show you some data about transplant being the optimal therapy, kidney transplantation for most patients with end-stage kidney disease. And although we transplanted the most kidneys into patients in this country in 2022, we still have tremendous issues with three things that I'll mention in the next several slides: wait lists, discard rates, and disparities in our systems that really could use some attention. So of those 104,000+ that were on the wait list back in January of this year, 90,000+ of them are waiting for a kidney. And 12 people die every single day waiting for a kidney transplant, a huge opportunity to do better. Next slide. So talking about the first of these three, the wait list, every 10 minutes, you have somebody being added to the wait list. And as you can see on the left and on the right bottoms, primarily the patients waiting for an organ are waiting for kidneys. So this is January, 88,000+, but as of July, we're talking about more than 90,000. And you can see on the right that although the wait list is quite large, we're talking about 25,000 of those almost 100,000 getting a kidney. Next slide. So talking about with the wait list, the recipients and the discard rate, these figures are directly from the SRTR. You can look them up, the scientific registry with transplant recipients. So this is specifically looking at deceased donors. And I like this just looking at the last several years, especially in light of the pandemic. Deceased donors continued to increase and increase. Living donors, however, took a little bit of a dip, has not quite recovered. Nonetheless, adding that together, that is a record number. But one thing that I think really is a travesty is the discard rate in this country. So back in 2020, more than 1 in 5 kidneys were discarded. And according to more recent data from this year, they really do think that from last year, the discard rate was 1 in 4. 1 in 4. Now you could say, well, maybe all of those kidneys really just weren't applicable. But when you look at discard rates from other countries, In France and the UK, the European consortium, which includes Germany, you're talking 8%. So let's say you have 12 kidneys. In the US, 3 of those would be discarded, but in Europe, only 1 of them would be. So you have 2 extra people for every 12 that would get a kidney coming off of dialysis or not having to start. The other thing that I think is really unfortunate, there are so many kidney, offers that come up that patients are completely unaware of. Where is the patient voice here? So there's a median of 16 offers declined per patient, and most patients are unaware when a team declines a kidney. That makes sense because oftentimes a system has a very short time period to say yes or no, and they may not be able to contact a patient, but nonetheless, the systems need to be improved. Next slide, please. And then going on to the third of the 3 issues, the issues around equity and disparities, I think here we again see a lot of improvement needed. There was a major report that was just put out last year about the promise of equity. And Black patients, for example, are much less likely than white patients to receive a preemptive referral, to complete evaluation, to get a living donor kidney. And they do receive lower quality kidneys on average in comparison to white patients. And then if you think about geography, rural patients, also socioeconomically disadvantaged individuals are less likely to get a kidney. Women are less often referred than men. Next slide. So knowing all of that, I think it's important to remind ourselves whether this is, whether this truly is the optimal treatment for our patients. So this is data from the USRDS, as well as bringing in a few comments from others that we know and love, Michelle Josephson and Sumit Mohan, who truly are well-versed in transplantation for our patients. We can see that all-cause mortality, of course, is lower for patients receiving a kidney transplant. And although their mortality increased in 2020, that was also the case for patients on dialysis. Next slide, please. But it's not just, I just wanted to mention also, of course, when somebody first gets a kidney, their mortality is higher just with regards to the perioperative risk. This is a classic figure from Wolf back in 1999. But we do see just after 3 months that the risk for an individual patient actually becomes lower if they've gotten that kidney transplant. And if you look at the population looking out 7, 8 months, survival becomes equal and then improved if you've received that kidney transplant. But not just survival matters. Next slide, please. Other things that are really important to patients matter. Hospitalizations, for example, of course, are lower in the transplant population. And you can see that in the bottom left hand and the upper right hand. We've also started following emergency department encounters. And you can see that those are lower as well over time for patients with transplants. I find this interesting just as a champion of home dialysis. This figure also shows that peritoneal dialysis patients were less likely to have emergency department encounters in comparison to hemodialysis patients. There's a lot to unpack there in terms of the health and the comorbidities of your average patient. But this is, something that's very relevant. In addition to all of these things that matter to patients, quality of life metrics and scores also are improved for patients on transplant over time in comparison to their counterparts on the wait list on dialysis. Next slide, please. So knowing all of that, we also want to see, hey, if it's, better outcomes, what about the cost? Are we paying more for these outcomes? Well, no. It's actually more cost effective as well. Again, not upfront for the first several months because there's a lot of cost perioperatively. But if you look overall at the transplant population, costs are substantially lower. Again, always interesting to look at that hemodialysis versus peritoneal dialysis lens, which is the dark blue versus red as well, with the gray line being those receiving a transplant. Next slide, please. So going back to some of the initiatives that have been out there, the Biden administration has made a major commitment to trying to improve some of these issues with the wait list, with the disparities, with the outdated system, which I'll go into as well. So HRSA, which is the Health Resources and Services Administration, I'll talk a little bit more about where HRSA sits in the government, announced very recently, this is again this year, that they are undertaking a modernization initiative. And our president of the ASN also advocated that this is truly a foundational step to help. So next slide, just talking about call for reform with this modernization initiative. Will continue. The goal is for accountability and equity. And these are the words you'll hear again and again: accountability and equity. And next click. We have a few more. So the iterative plan is to focus on 5 key areas. So technology in particular, there was a major report put out by the US government specifically about the system for transplantation. Some of the programs are still run in MS-DOS. Now, for those of you who don't know what MS-DOS is, that's because it's so outdated. It's a system that's been in place for decades and decades. And next click, data transparency. So many patients don't know where they stand on the transplant wait list. Some of them don't even know if they're actively waitlisted. I had a discussion with one of my patients just yesterday, and he thought he was waitlisted. He was sure he was active and he was sure of it, and that was not the case. Next click, the governance. The board of the current contractor is the same as the board of the OPTN, the Organ Procurement Transplantation Network, which is part of the government. That means that there's a huge conflict of interest and not good oversight, something that needs to be remedied to make sure things are being governed appropriately. Next click of 5. And so operations, just making sure that things are moving forward appropriately. I'll talk about that when I talk about UNOS, which is the group that holds the contract. And then the last of the 5 is quality improvement. And the metrics that are out there really need to be overhauled to make sure that we're thinking about giving patients the right treatment at the right time. So onward, next slide. So let's unpack this a little bit. There's a lot of letters and alphabet soup here. So what are all of these things? So OPTN, just again, that's the Organ Procurement and Transplantation Network, which is a division of HRSA. What is HRSA? HRSA, as I mentioned, is the Health Resources and Services Administration, and that's a division of HHS, which under the Secretary Becerra reports directly to Biden. UNOS is the contractor for the OPTN contract. A lot of people interchangeably think that UNOS and the OPTN are the same thing. Well, that makes sense because they're the only group to have held the contract in 37 years. So they're often thought of as synonymously. And the board of one is the same as the board of the other. Again, a huge conflict of interest, and that's recognized by many people. Next slide. And this next slide to me is more complex than the complement cascade, but nonetheless, I'm not going to go through all of this. It's just to demonstrate that there's a lot of complexity here. HHS is the group that directly, that's, there's a seat in the cabinet that directly reports to Biden. And HHS is overseeing not just HRSA, but other groups like Medicare. So it gives you a sense of where things sit in the government. And the OPTN, the Organ Procurement and Transplantation Network, is part of the Division of Transplantation under HRSA. The other group under the Division of Transplantation is the Scientific Registry of Transplant Patients, recipients. And we'll see some more data from that in the next couple of slides. Next slide, please. So let's talk a little bit about the history here. How did it get to be that we have this system, this Department of Transplantation? So Congress passed NOTA, the National Organ Transplant Act, back in 1984, and that established something called the OPTN that we've already discussed. And this was supposed to maintain a registry for organ matching. It's a network that was supposed to be operated only by a nonprofit under a federal contract. So this federal contract was finally awarded to UNOS, the United Network of Organ Sharing. So this is the contractor, but they have held this for 37 years. It's basically been a monopoly. Other people can't quite get in there because one of the requirements of the contract that needed to be changed by an act of Congress is that you had to have at least 3 years of experience doing this. And you can't get experience doing it unless you've already been doing it. So it really made it difficult for other people to try to get this contract. So this left the US government with a monitoring function only to make sure that UNOS followed all the statutes rather than the typical type of oversight in the more regular relationships that the government has with its contractors. Some of the concerns I've already mentioned is that IT modernization, there was no absolute authority to say you had to have IT modernization. So for example, there's a lot of local data being used as opposed to a uniform cloud computing group system. And UNOS also is not actively sharing its data formats. It's one of only 100 plus groups in the whole country that's a contractor. Again, the whole system has been paid for by the government, by taxpayer dollars. So that is interesting. As I mentioned, it's hard to award this to other contractors. And UNOS really uses US funds to create the systems. And as I mentioned before, other concerns is issues like the discard rates that are so substantial. So next slide. Want to talk a little bit, I showed this slide before, about this major commitment. In order to do this, this is HRSA on the regulatory side. In order to make sure that you have changes to the contracting system, you really did need to have legislative changes. So next slide, please. As I mentioned, we needed a true act of Congress, a literal one. And so the Senate Finance Committee, who is led by Senator Wyden, as I mentioned, he was that tall gentleman in the picture next to Biden, began a bipartisan investigation along with Senator Grassley from Iowa. And that resulted in a 66-page memo that was discussed in a hearing in 2022, about a year ago. And it said in this memo, the system is in need of repair. I mentioned all of these items before, except for the improper use of Medicare funds. And with that, they introduced in 2023, the spring of 2023, a bill, the SUS-OPTN bill, securing the US OPTN Act. And this passed not only the Senate, but the House as well in record time. We're talking months. It took 10 years, 350 plus months to pass legislation about covering transplant medications. It just gives you a sense of how quick the government acted here. It gave HRSA the statutory authority to improve management and to really import initiatives and break up this contract so that we could award this contract to people who had specific expertise in all the areas like IT expertise. Next slide, please. So this was the act. You could follow this on congress.gov, and ASN, for example, was one group that advocated very strongly on the Hill before it passed. This was in July 21st, and things passed, was, moving forward to have the passage that happened on July 31st. So lots of work by a lot of advocacy groups. Next slide, please. This is where I'd been following the story pretty intensely, but this is where I got deeply involved. So the Senate bill passed in late July, and Wyden really acted very quickly. And less than 2 weeks later, he called for a roundtable. And it wasn't just him. This was an auspicious roundtable in terms of the US government. He actually got the cabinet members, Secretary Becerra, who you can see in the picture on the left, that's him on the right, coming, and the HRSA administrator, the person who's in charge of all of HRSA, Carol Johnson, who's the woman with the long blonde hair sitting next to the secretary in the picture on the right. They all came together and they had a roundtable. There were 5 physicians there. I was the sole person representing dialysis and people on the wait list. In the adult population, the other 3 physicians were either transplant people or policy people. And then there was 1 person representing the pediatric population. And they really wanted to hear, how can we make things better for patients? It wasn't just lip service. So these are the kinds of things that they're trying to convene in order to just shape the future in terms of the policies that we will follow for our patients' benefit. Next slide, please. I'm not going to go through all of these details, but they're really trying to think about, how do we transition contracts as we move forward to the future, so patients don't get left behind. Next slide, please. This happened just in the last couple of weeks. Jean Moody Williams, who's the deputy director for the Centers of Quality, basically, for Medicare, established an organ transplant affinity group that hopefully will strengthen accountability, equity, and performance. And they put out a huge action plan that just got put on the CMS blog, was dated the 15th of September, but didn't get put out there until, basically 1 week ago, as a plan of action, again, to be implemented. They need input. Next slide, please. And this is what OTAG said. I'm not going to go through all the details here, but I do want to put on the left side into your minds the 2 aims. They're looking to improve the system for performance and with regards to equity. You can go on the website and look at this action plan about the various goals and the various strategies that they're trying to lay out so we can improve the system moving forward. So much to be done, and we need everybody's voices if you have interest. Next slide, please. Okay, so I've been, telling you all of this, but what can you do? What can we do? Well, first and foremost, you should know your data. What are the transplant rates in not just nationally that I mentioned, but also locally? How do they compare? And then how can we advocate? Who should we be talking to? Who are our local legislators? What do they think? Should we be helping to change their minds if they don't have the patient perspective? Or who can we put in front of them if they don't know about it? And then how can we advocate nationally? There are a lot of groups that are really pushing right now. ASN has a loud voice there. The National Kidney Foundation, Kevin Longino advocating. He was actually at the signing of this bill. The American Association of Kidney Patients, RPA, ANNA. Your voice really matters, especially right now as all of these policies are being drafted. So talking about what's the data and who can you advocate to? Next slide, please. So I pulled this data off of the SRT, our website, just a little while ago, but then I looked it up again yesterday to make sure it was still accurate. So you can look at all of the data for, the whole state of Washington, the whole, even larger numbers of miles. But I looked in the Seattle area at UW versus Virginia Mason versus Swedish. And you can see how many patients, for example, were transplanted in the last year. And the bars, you can see that there's 1 to 5 bars here, getting a deceased donor transplant faster. 3 is average, 1 is very low, and 5 is very fast. So you can see at UW, for example, we got 4 out of 5. That's a little faster than average to get a deceased donor. And the 1-year kidney transplant survival, that's the best, 5 out of 5. Versus Virginia Mason that also had the 4 out of 5 and the 1-year kidney survival of 4 out of 5. And then Swedish coming in on average. And you can say, oh my goodness, doesn't that look like we're great? Well, there's a lot to unpack there. Are we accepting patients, for example, that are the same as Swedish and Virginia Mason? And I'm not going to comment on that. I did see Nikolai and Iris, and there are probably other transplant folks on there. So if we have a few minutes at the end, maybe we can hear from them and their thoughts. So this is some of our data. Next slide, please. A little bit more of our data. It's nice to know this is specifically UW, are observed versus expected. The rate of 100-person years, it's really a high observed versus expected rate of transplant. And that's wonderful. We can say that to our patients as they get on a list with us. And you can look at rates for adults. Again, we're not talking about pediatric because we're not transplanting the pediatric population. In terms of our OPO, our organ procurement organization, versus the region versus the US. Again, we're doing really well. And then that little red dot in terms of transplant rate ratio estimate, it just basically, again, shows that we do a little bit better than average. And this is confirmed as of the 29th of September, that this data is accurate. And it is relatively real-time data. They update this frequently. Okay, so that's our data. Next slide, please. So I told you that we should be talking about kidney health and talking to our legislators. Who are they? So hopefully you know who our senators are. If not, here you go. Patty Murray and Maria Cantwell, they've had health legislative assistants who have been very well versed in the kidney space. And also the congressional contingency. I didn't put everybody on, but of the 10, here are the first 6. And you should really know Susan Del Bene, who is the Democratic co-chair of the Congressional Kidney Caucus. Yes, there's a National Kidney Caucus, if you don't know. And she is extremely well-versed in all of these issues. In fact, she held a roundtable that was at our Bellevue Kidney Center. Yuharn was there. It was wonderful to have her. And she's very interested in making sure that things go well. Next slide, please. I'm not going to go through this because of time. Next slide, please. And so just with regards to summary, I just wanted to make sure that everyone was aware of some of these recent national initiatives to transform transplantation, that the data show benefits of improving patient access to kidney transplantation, and then the current policy and advocacy efforts that are being created and implemented now. And I really did want to emphasize that although you may think otherwise, government can be effective in implementing change. Next slide. And I just wanted to acknowledge everyone in the kidney care community, Northwest Kidney Centers, of course, UW Nephrology, every single one of you, the VA Puget Sound Healthcare System, who has supported so many of our patients, allows me to care for people, and every one of you for your interest, as well as our advocacy group. So that is it. Kate, you can take down the slides. And if anybody has questions, I think we're just on the half hour. Would love to hear from all of you.
Thank you so much. I'm sure that there's plenty of fodder for discussion. Understand if some of you need to trickle off, but in the meantime, any questions for Suzanne?
And I see Glenda here. I'm so glad that you joined, Glenda. As a patient, as you've said, I'm not just revealing anything that you haven't said to others, and as a huge advocate for all of this, I'm just so glad you're here, because that's why we're here. We're here to benefit patients and to improve the system, a system that is doing a lot of good for a lot of people, but we can do better.
Thank you, Suzanne. And I was especially glad to see that in your second point, you emphasize the importance of patients. And I would encourage everyone to start looking at how we communicate data to people who think they're on the transplant list. It is very difficult as a patient to tell where you are in the process, which gates you've made it through, whether or not you've been stopped, or if there are things that you need to do in order to make further progress.
Thanks, Glenda. And I see Brendan has a hand up too. Brendan?
Hi, Suzanne. Thanks for the talk. As you know, transplant listing rates were recently added as a quality measure for dialysis organizations. And I was just wondering if you had an opinion on exactly what dialysis organizations have to do with transplant listing. And then just kind of a related observation to that question. UCSF is a bigger transplant program than UW. They transplant about 3 times the number of patients that we do, but they have about 10 times the number of patients on their wait list, the majority of whom will never be transplanted. So by the government's quality metric, those patients in dialysis units listed at UCSF are getting somehow better care by their dialysis unit. And I'm just wondering how that decision, if you had any insight into how that decision came about.
I don't quite understand that last part of the question. They're getting better care by their dialysis organization. You mean because
well, according to the quality measure metric.
Yeah. So there's a lot to unpack there. as you know, I could probably do another half hour just answering the questions that Brendan asked. I'll try to be succinct. So just as a statement for people, there are metrics now, both in the star ratings and in the quality incentive program, about prevalent patient waitlist rates. And in fact, in the star ratings, there's also a measure about incident patient waitlist rates. Now, you can't imagine that a dialysis organization is going to be able to make that much of an impact in the incident transplant rate in that first year, but you never know. However, the one thing I will say is that a dialysis facility is a place that a dialysis patient, whether they're on home dialysis or in-center dialysis, they have a lot of contact with the system. And with regards to the conditions for coverage, you're required as a dialysis organization to talk to patients about transplant, make sure that they're aware, and to assess them. And every dialysis organization has some group that is responsible for making sure that they discuss the options of transplant with patients. So, for example, for Northwest Kidney Centers, it's the social workers and that group, as is many of the dialysis organizations. And so as we think about moving forward and trying to be more of a system rowing in the same direction as opposed to a siloed care system for patients, the dialysis organizations are doing a lot more work to partner with transplant programs, with systems that can work for patients, with the nephrologists, especially under value-based care systems, to try to do better. For example, the ETC, which 30% of all dialysis patients and organizations and nephrologists have been randomized to, has a metric about how well you do with transplant, and you're given either financial penalties or bonuses, depending on how you do with those transplant rates. So dialysis organizations now really do have skin in the game. So I do think it's reasonable to hold dialysis organizations accountable to some degree for transplantation awareness for patients, because if you don't know about transplant or how to contact people as a patient, you're not necessarily going to be able to reach out to those resources. So although it's not perfect, Brendan, and we're still working to do better, I think it's reasonable. And I won't go into the UCSF issue. I'll talk to you offline about that. And I just would say that moving forward, I hope that all of us can speak about this, because our discussions, our comments to the government, our advocacy can make a difference in terms of what metrics are used and how we can do better for those patients trying to get optimal therapies. Thanks.
Yoonharn?
Suzanne, thank you so much. That was an amazing presentation. One of the, I suppose it's a question and a comment as well. So what you've shown is a lot of waitlisted data and transplanted data, but the patients who are really not visible are the ones who don't get on the wait list. So what are the efforts that are being made right now to make that data more visible? Because if we don't measure that, we're never going to tackle that.
Absolutely. If I'd had more than a half hour, I would have included that as well, Yoonharn. But because there's so little that's out there right now about it, I did not. What I will say is Carol Johnson, who's the administrator for all of HRSA, the woman that you saw in that picture, that is her specific concern right now. She wants to know how we can capture data in the black box from when patients are referred until when they're waitlisted. It's an issue that's really forefront for SRTR, the part of the Department of Transplantation, also under HRSA. And so stay tuned, because you will see something about it. It's a huge black box and we need to do better. I'll stop there because of time, but thank you for bringing that up.
Of course, totally agree that's an important issue, and more to discuss there. I'll close for time, but thank you to all of our presenters. Especially liked that we had this nice potpourri of research, clinical, application, and policy. Great representation of nephrology. So with that, everyone have a great weekend. Looking forward to seeing you at our next session.